biomedical instrumentation and life support systems. He holds 16 patents, published over 40 papers, and delivered 50 plus technical lectures. He is a life member of several engineering societies and reviews for top journals. I would welcome you, sir, on the dais. For giving a moment of respect, a token of appreciation, I would like to call Ms. Charu from ICRC. Shri Praveen Kumar, Chairman and Managing Director of LMCO. He has more than 28 years of multifarious experience in PSUs, private MNCs at multiple locations in India and abroad, including Middle East and African countries. Sir, I would request you to come on the dais. For giving a moment of appreciation, I would like to call Ms. Soumya from Oblite India. Over to you, sir.
Yeah, very good afternoon to all the participants here and then the speakers. And thanks for the organizers to invite us, me and sir, to chair this session. And it's a bit of a hot session after the lunch. I hope the speakers will make it very beautiful and then very innovative things to learn. So after the food for thought, really the thought process, let's go on. So I'd like to invite the first speaker, the plenary speaker, Dr. Ravinder Singh, the Senior Scientist, Disability, Rehabilitation and Assistive Technology, Indian Council of Medical Research, New Delhi, India. He will talk on the title on Rehabilitation and Assistive Technology in the Indian Health Systems. So as in any healthcare systems, we'll have a localite based and then also the covering the overall systems. So I think Dr. Ravinder Singh will make complete overall systems, how the both mental and rehabilitations, how it works in Indian systems. As he is reading from the ICMR, he is the right person to deliver the talk. And he holds to content about that is academic and well as his experience. He is a PhD in public health, has a rich 20 years of experience at ICMR, specializing in mental health, disability, and assistive technologies. He also collaborates with the WHO to integrate assistive technologies into Indian health system and is recognized for his significant contribution to this field. None other than Ravinder Singh from the Indian Council of Medical Research, who can else to give this complete overall the systems the Indian medical system has. So please, sir. Thank you.
Thank you, Dr. Mohanavelu and Shri Praveen Kumarji. And dear friends in the audience, I'm not a person from the area of disability, as you know, and I don't know anything about disability. That is also the fact. So started in this area around 10 years ago with my official responsibility of creating a research environment on assistive technology, disability, rehabilitation. So we started with constitution of a huge working group. And then that group actually guided us. It was diverse group which gave us the directions and how to move ahead in the area which was not my area of expertise. So it is all because of that group and that team which showed us the path how to move ahead. So today the responsibility was given me to share the ecosystem which we have created over last 10 years. And it gives me great pleasure also to share that within this time, we were able to get the UN award just last month. So that was not for me, that was for whole of India and the team which worked and the experts which guided us during this journey. So I know I would fail in my duty if I don't mention the names which, guided us, especially because I can't tell all the, can't remember even. So starting with the WHO Zero office, Dr. Patanjali Dev Nair, and then of course Chapal from the WHO headquarters. He was the one main force behind it to take it up. And then because of their vision, and Chapal just entered now, I just mentioned about him. Because I don't know from where they got this idea of assistive technology, which is actually, cutting across the areas. And I could never think that somebody can think in the so broad way that these are 7 domains. They said 6 domains, I said 7 domains. So still they are stuck to the 6 domains, starting with the physical, mobility or locomotor areas, visual impairment, hearing impairment, cognition, communication, and self-care. They stopped there. I said, no, what happens to the people who want to play? The sports, recreation, and leisure activities. As I worked on this area, more and more I was convinced that this is very important. A very small example I will give you. We were, roaming around on Trivandrum beaches, and we found out one couple, a blind man with white cane and women with elbow crutches. They are trying to go into the sea and try to feel the beach. And I took that photo, and it was really memorable, and I have shown it in many of the meetings like this. Today I could not prepare my slides because of various other engagements. But anyhow, that is not important. But the thing is that these 7 domains and then 5 Ps, they said that you should work on the 5 Ps, that starting with the people. So everything, surrounding the person who need it. So these 7 domains with 5 Ps and 5 Is and then now 6 Is. So, so we started working on that area. 5 Ps is the people and then policy for them, and what are the products and how to provide them and who will provide them. So personal. So simple, 5 Ps. So we said, okay, we'll start working on this area, and it was in 2017, Chapal knows very well, when we first organized regional conference at, then it was called Pravasi Bharatiya Kendra in Delhi. So we invited experts. That was the first experience, and we got a lot of good inputs from the people, not only from India, from the neighboring countries. We came out with a small report, which is submitted to WHO Zero office, and then we actually came to know that the gap and the need and then the scope of work. After that, they came out with APL, Priority Assistive Product List in the morning, as it was displayed. Chapal was again the guiding force for APL list. And then he said, there are around 2-3 countries which are taking it up, and India should also come out with its own APL list. I told him that India has a national list of essential medicine, NLEM. So it will be much easier for me to pitch in if I say this is national list of essential assistive technology. So NLET, that was the starting point. He said, we have assistive product. I think you should also go for the assistive product. Don't say assistive technology. So at that time, I was so immature, I never knew the difference between AT and AP and assistive devices and all that. But my guide and mentor and then expert was there to guide me and to sail through this area. And then we had a very raw list of 383 products, which was at that time, at the time of the COVID, in 2020, we published it on ICMR website. for the public comments. And I got around 1700 comments for not to, take it further. Because this is faulty, this is something which is not useful, and all those kind of comments. And some of them might be from this audience also. So, and then it was shelved because the priority of India was at that time managing COVID. My DG said, what is this nonsense work which you are doing? Don't do it, just shelf it. So we shelved it. And then at the same time, Chappell said, you come out and contribute to the GREAT report. The GREAT report is the first report in the world which looked at overall scenario of assistive technologies. That global report on assistive technology was the first document in the world for which we contributed. We actually asked for 2 chapters, they gave only 1. I don't know why, what's the criteria? I still wondering. So we were asked to, improve the access to assistive technology. That was the chapter which they asked, and we contributed, and then beautiful report they published they came out with the GREAT report in 2022 May. So that was again another step ahead in this direction, that what to do and what not to do. So we came out with earlier the raw list of national list of essential assistive technology and this GREAT report. And then again, last year, 2 years ago, when our new DG took over, he asked me, what are the areas you are working? And that at the same time, we were also able to convince the, policy makers to have a center which will innovate in assistive technologies. So that center was, I actually wanted it to be named as CReaTe, Southeast Asia Regional Center for Assistive Technologies. Because the WHO was convinced that you should go for the global leadership, but at least take the Southeast Asian leadership. So we named it CReaTe, but then again, my DG said, no, aim little low, first make it as a National Center for Assistive Technology. So originally that was called NCAT, National Center for Assistive Technology, and that was 100 crore rupees budget. And when it was projected to the Ministry of Health and Ministry of Finance, so I had to go and present that. So I presented, and then the financial advisor at that time was, he's the president of one of the AIMS. He asked me a question, how you differentiate between assistive technology which are used in the social sector, which are used in the health sector? Actually, there is no difference, but you have to justify your actions, why don't in the A and T? I said, sir, if you are ready to give me 100 crore, I'll add H, I'll add any other word which you want. So he said, I'll give you, just add health. So that is how the National Center for Assistive Health Technology was born. So we identified AIMS Delhi and IIT Delhi. So I have time? Okay. So that IIT, this was the first experiment to combine the technology people and the health professionals. How to you go ahead? Still we are actually, creating the links between both of them, but we have been fairly successful in doing that. So now that National Center for Assistive Health Technology at IIT Delhi looks at the visual part, and extensive work has been done. There is experience zone there in IIT Delhi, and anybody who is interested, I think they should anytime, you should go. There are another 2-3 experience zone which I have seen there in India is the Blind People Association experience zone at Ahmedabad, and then this, and now Dr. Gauri Sen Gupta is also, she is very keen on creating that kind of experience zone and skill lab. So actually we are halfway through that. So that is the journey which we have, gone through. And then after the NCAT was created, then my DG said, how you move ahead out of this 5P, which P you would like to take first? So I said, the policy will take time. So let us, on the pattern of APL list, we will go for NLEAP, National List of Essential Assistive Product. So that's the beautiful document available online. Anybody want to download, you can download it. It's in PDF form. So just Google it and leap ICMR. So this document will come. The beauty of this document is that essentiality of the assistive product is there, which means the government is now ready with the larger plan to take up this area and develop it further. So the national list of essential assistive product contains around 21 groups of products, and I'm very thankful to Rajesh Agarwal ji, who took it immediately, and that was the most satisfying experience, that Ministry of Social Justice took it up in its toto and they worked on it. And it actually was great satisfaction and great support for us that, yes, whatever we have done is now getting the, support from the highest level. And he is very, sportive, and whenever we have invited him, he is available all the times. Thank you, sir. So then after the NLEAP, then around the NLEAP, we started working on it, and around the standards, then awareness, the training program. Again, the WHO was very handy to come in, and we found out some training modules are already available, but Dr. Gauri Sen took this challenge, and she said, I'll work on the training modules and also the awareness material. And at the same time, NIPMR, they were working on some model or training modules in Trivandrum, in Thrissur area, I think. Thrissur, right. So NIPMR is also keenly, very strongly and very, focusedly working on the training modules, and also creating the, environment for taking up of this assistive product at the primary health center, community health center, the tertiary and, district level. So that would be a next step when we move ahead. So, and also at the same time, Niti Aayog came out with one draft national framework for provision of assistive technology. And still we are working and discussing it. It has gone through many phases of discussion. So that is another area. And then standards. Immediately Niti Aayog took that NLEAP document and sent it to BIS, Bureau of Indian Standard, for creating the standard on these 21 group of products. So 21 assistive products which are there in NLEAP. And actually they were supposed to launch it this year, but we could not find the standards for 4 products. I think it was portable ramps, therapeutic footwear, some orthotics products also, and there are 4 products for which the standards could not be found in BIS list or ISO list. So we are still struggling, and there is a big challenge for us to come out with the standard for therapeutic footwear. Is very difficult task. I traveled across to Bosco. I traveled to even last week I was there in Netherlands, tried to find out from the Puma and Adidas companies. So whether they have, but the thing is, even if they have, they are not ready to share it. So we are, I am trying to
Sir,
talk to...
2 minutes.
Okay, so I can stop right now, no problem. But the thing is that journey is very interesting, and I'll finish it in two minutes.
Thank you, sir. Thanks a lot.
So there is a organization called FDDI, Footwear Design and Development Institute, somewhere in Haryana, in Bhadragarh. So I came to know about the MD, and then now I'm trying to, contact them. And I'm very sure that we will find out the solution for that also, and portable ramps and some of other products. So I think during this period, lot of work has been done. Before me, I only knew that NISH has a CReaTe Center for AT Innovation or something, CATI. So I went there, looked at that center, and that at that time, they had also made some, modules, online training modules, and then some of the, courses they have made. So overall, in this period, now the assistive technology is such a common word. Whenever And 2 days ago, when I was traveling through, the plane, so some Deputy General Manager, Mr. Saurabh Bajpayee was there. He was traveling with me, and niche people had told that he will be traveling. So then I actually found out within the plane that where is he, and I tried to, find out what SIDBI is doing. And then he told me that STPI, Software Technology Parks of India, they have taken up this issue in a very, very big way. And they are coming out with some around 4 hubs for assistive technology innovations. So looking at those, all the scenario, we are very confident. And then we also had a project collaboration agreement with WHO headquarters, where there are, 6 deliverables. And one of the deliverable is the data from India. And WHO made a very nice tool called RATA, Rapid Assistive Technology Assessment Survey Tool. And we are using that tool in 25 medical colleges across India to collect the data out from 180,000 people. And that would be again a very good data, because we have done the trainings. Last 2 months I was training in those all 25 medical colleges, giving the training. And Dr. Deepti Shanwal is here, one of the principal investigators, and they are very happy to actually, I think whosoever the principal investigators, they are putting all their efforts into it to get the good data. I told them that you are going to be part of the history, because that data will go to Global Health Observatory, WHO, and also to the next great report going to be published in 2026. So the RATA's information, whenever it comes out, is again going to be one feather in India's progress in this area, and work which we have done in this area.
Sir, thank you, sir.
So I'll stop it here, and any questions, I'm not available. Thank you very much.
Yeah. Sir.
Thank you so much, sir. A small announcement. There will be parallel sessions in hall number 2. Please note that. Parallel sessions in hall number 2 now.
Very good afternoon, all. I know it's very difficult. After the lunch session is very difficult. I can see people getting very... Anyway, as we know, innovation is the key in today's world. Unless we innovate, we will be obsolete. Whether it is disability, whether it is assistive technology, whether it is any technology, if we don't innovate, we will be out of question. So in this series, I would like to invite Maritha Dawson, who is the co-CEO, Shona Equip, South Africa. She has been empowering mobility by customizing pediatric devices for South African children with disabilities. She has 14 years of physiotherapy experience in South Africa's public health sector and has advanced to the leadership role at Shona Equip Social Enterprise. She is pursuing a master's in public health focused on disability, overseeing impactful programs and team management. Welcome. Thank you.
Okay. Thank you very much, and thank you for the opportunity to be here. I would just like to start off with some disclosures. The content of this case study has not been published. Uhambo's Wheelchair Fund funded the device in question, and Shona Equip is the manufacturer of the posture support device. Okay. Historically, children with mobility impairments in South Africa have not had access to appropriate wheelchairs, which significantly impacts their participation and inclusion. Despite transformations in policy, gaps still remain in ensuring that the right to suitable devices is being realized. Access to assistive devices is poorly quantified in many lower and middle income countries, with the World Health Organization reporting only 15 to 25% of people with disabilities who are in need of assistive devices actually having access to them. In an ongoing survey among South African parents to explore the question, does your child currently have all the devices they need to be as safe and independent as possible? Of the 560 responses, more than 70% answered no. The WHO outlines that an appropriate wheelchair needs to meet the need of the user and the environment, provides good fit and postural support, is safe and durable, is available and can be serviced and maintained in the country at an affordable cost. This presentation will use this criteria when referring to appropriate wheelchairs. I would now like to introduce you to Sia. Sia is a 14-year-old boy with cerebral palsy. He lives with his parents and younger brother. He enjoys going on family outings to the beach and shopping for his own clothing, and he uses a wheelchair to move around. Unfortunately, Sia did not go through the adequate assessment, prescription, and fitting process. Rather, the wheelchair that he's using has been donated to him. His experience highlights some of the barriers such as availability and affordability of appropriate devices, poor awareness and lack of knowledge of these both amongst users and service providers, and poor implementation of policy faced by those trying to access assistive technology. This presentation will demonstrate Sia's use of an innovatively designed South African manufactured pediatric posture support mobility device. The relevance and positive outcome of the assessment, selection, fitting and follow-up process will be described. Shonaquip has been designing and manufacturing posture support devices for over 25 years and is well aligned with the global standards of wheelchair service provision. Seating systems are modular, meaning that the base frames are all interchangeable with the posture support seats and are suitable for both urban and rural terrain. If we take a look at Sia sitting in his donated device, you will see that it is too wide for him. So it's not providing optimal fit and postural support. He has no seat cushion. This places him at risk for postural malalignment and pressure injury. His backrest is too high, and that interferes with his shoulder mobility. No trunk support puts him at risk of developing a spinal deviation. The lack of seat cushion and non-optimal backrest resulted in him sitting in a posterior pelvic tilt with a thoracic kyphosis. Limited adjustability of the footrest resulted in poor foot support. Due to the device being too wide and the tall armrests, Sia struggled to reach the rear wheels to propel himself efficiently. Environmental needs were also not met, as this wheelchair was extremely tippy when propelling over uneven terrain. Sia's mom reached out to Shonaquip's clinical team because she had concerns of her son's reduced independence in his wheelchair and how it affected his inclusion. Through assessment, trial, and consultation, it was clear that Sia was in need of a device which suited him in various contexts. He had neutral lower limb ranges for sitting, but he tended to side flex when propelling and sits with an exaggerated kyphosis if he doesn't have firm trunk support. He received a wheelchair fitted with a rigid back system called the test back. He also received a pelvic strap and a seat cushion which was adapted for positioning of his pelvis. The skirt guards allowed easy access to the rear wheel. This combination provides Sia with optimal postural support. He needs to be upright and independent in his device. The test back is a rigid back system with over 30 different back height and side support combinations that can accommodate users with intermediate and advanced posture support needs. It can assist with maintaining optimal trunk alignment and promoting the healthy development of spine in children. It also reduces the onset of progression of spinal deviation in adults. This back system can be mounted onto various types and sizes of wheelchairs and can assist with transforming a basic wheelchair into one that provides posture support, such as in Sia's case. It's available in sizes 8 to 20 inch with standard and customizable options to both the laterals and back heights, and one can further customize the backrest by mounting a headrest directly to it. During the wheelchair service process, Sia's mother was educated on appropriate wheelchairs. She is now also part of Shonaquip's parent network. This is a national peer support and training group for parents with children with disabilities. Here she can share her knowledge now with other parents, and she has been empowered to start addressing barriers to inclusion, such as stigma around disability in her own community. After fitting the new device that meets WHO criteria for an appropriate wheelchair, Sia's quality of life was reported to have greatly improved. The device is well suited for his environment and his posture support needs to enable both independence and community engagement. It will also be adapted to accommodate his physical body changes as he grows. The test pack is easily removable from the wheelchair, and the wheelchair is compact enough for his mom to fit into a car. She reports that he now pushes himself with ease around their home and during social outings. He can join the family comfortable at meal times by sitting at the table with them, and he enjoys racing down the road with his brother. The device that Sia is using is available locally and therefore can be easily maintained and repaired. Yeah, I'm almost done. If it will just go, there you go. Sia continues to use this device daily, and his words to his mom after receiving it was, "This is my Rolls Royce." This case study highlights that the off-the-shelf wheelchairs with their static design can potentially fail to meet users' needs. As Sia's story shows, locally designed adaptable posture support devices are essential for both physical health and social inclusion. Given the diverse needs amongst wheelchair users, wheelchair design should be customizable to meet individual needs. Adjustable features like height and width, along with modular components that accommodate different body types, growth stages, and changing needs over time are all beneficial. As Sia's case shows, the value lies in thorough assessment, appropriate selection of locally available devices, and proper fitting when issuing wheelchairs in any context. His story also highlights the importance of support and education of family members in both the direct wheelchair services, but also support services that complement this. While addressing barriers that prevent access to appropriate wheelchairs feels daunting, Sia's case highlights some recommendations for therapists. We need to spread awareness on the criteria for appropriate wheelchairs to people with mobility impairments and their families, health professionals, and other stakeholders. We need to remember that appropriate posture support can be achieved through selecting components, such as a back system, and matching these with basic chairs in order to meet unique users' needs, if this is what is available to you. And we need to remember to consult the wheelchair user and their family when we select devices to ensure that their requirements are truly considered. I would like to end off with a quote by Dr. Vic McKinney from the Department of Health and Rehab Sciences at the University of Cape Town. "The difference an assistive device can make to someone who is disabled can be everything. It provides a gateway to their life." Thank you.
Just 2 minutes for question and answer, if anybody.
There's no questions. Can I go?
Thank you.
Thank you very much.
Thank you, madam. We invite next speaker, Dr. Vikrant Nagaraja, Research Fellow, University of Salford. Again, he'll be talking the same theme of the design, innovation, and development of CReaTe. It's a co-creation of an AT provision and repair registry, a step towards data-driven rehabilitation service provision. Dr. Vikrant Nagaraja is a PhD graduate in biomedical engineering from the University of Oxford. He is now the University Fellow at the Salford University. He specializes in upper limb prosthetics, rehab technologies, and affordable healthcare solutions. Over to you, Nagaraja.
Thank you so much for the kind introduction. Hello all, good afternoon. Welcome to today's presentation. And today's talk would be on co-creation of an AT provision and repair registry, a step towards data-driven rehab service provision. Globally, over 2.5 billion people need one or more AT products. And because of an aging global population and rise in NCDs, it is estimated that over 3.5 billion people would need AT by 2050. And especially in developing countries, most people who need AT do not have access to it. Health economists have estimated that a fifth of spending on healthcare in OECD countries is ineffective and have issued a call for action. Barriers impacting access to AT include high costs, workforce capacity gaps, insufficient funding, AT sector fragmentation, and socio-demographic obstacles. Danemeyer et al. Note that understanding AT access facilitates meeting AT needs and concluded that longitudinal data on AT access are a critical component for planning policy and provision. Collecting a global data set indicating what kind of data are available and where can help identify current data gaps, opportunities to learn from existing data, and recommendations for improving data collection going forward. So there are some numerous benefits in terms of adopting a big data approach. I'll sort of highlight some of them. Combining data increases the total sample size and therefore power, while minimizing the labor and resource impact on any one contributor. Low average statistical power of studies can lead to overestimating effect size and low reproducibility of results, making the research unreliable, inefficient, and wasteful. Large-scale collaborative consortia in fields such as human genetic epidemiology have transformed the reliability of findings in these fields. For example, large data sets such as the UK Biobank have been pivotal in driving healthcare and medical research in the UK and elsewhere. And also, this approach spurs research and collaboration. For example, there are over 13,000 research articles on Google Scholar that mention the National Joint Registry since its inception 2 decades ago. And then you might ask, why registries? Medical registries, in a very cost-effective manner,